Dr. Mint.
Thank you very much, Professor Muller, for the introduction. Günaydın. But now I'm going to switch to English because that's the only word I learned this morning in Turkey. So today I'm going to discuss about immune system and tryptophan metabolism interaction in psychiatric disorders, and I will focus mainly on pharmacological aspect. So when we talk about psychiatric disorders, so we know that psychiatric disorders are not just a state of mind, but I would state that psychiatric disorders are the disorders of mind. But I don't mean mind as something just philosophical and not scientific thing. Why I say mind? Because mind reflects human lives. And the psychiatric disorders, we can find the abnormalities in our body, immune system, endocrine system, metabolic changes, and the genetic is also involved. And these different systems in the body interact with external environment, physical and psychological stress, and these interactions induce some neurochemical changes in the brain. So the interaction between external environment, internal environment, and the brain, that means the human lives, and that is the mind is the reflection of human lives. And immune system may be not the only system involved, but this can play as a pivot in this pathophysiological mechanism of psychiatric disorders. So today I will focus on the interaction between immune system and tryptophan metabolism. So I will briefly explain about the immune system. So I suppose you all learn from medicine that in the immune system we have some inflammatory responses. So inflammatory responses are induced by the molecules that induce inflammation. So we can define them as pro-inflammatory molecules. And there are other molecules that balance the effect of pro-inflammatory molecules. So these are anti-inflammatory molecules. So when we have inflammation in our system, we have pro-inflammatory molecules. And when we don't have these pro-inflammatory states, in our body, the tryptophan is the precursor of serotonin and melatonin, the neurochemicals we need for our normal daily mood. And this tryptophan can be degraded into kynurenine in normal state by tryptophan 2,3-dioxygenase enzyme. And the activity of the enzyme is controlled by the tryptophan level itself. So in normal condition, this breakdown is normal and the whole system is normal. But when we have stress, cortisol can activate this TDO enzyme activity, then the breakdown can be enhanced. And also when we have inflammation or activated immune response, then we have increased production of those pro-inflammatory molecules, and these pro-inflammatory molecules can activate another enzyme which is called indolamine 2,3-dioxygenase, so in short, IDO. IDO and TDO. So IDO can also degrade tryptophan to kynurenines. So what is the difference? TDO presents mainly in the liver, but also in some cells like certain neurons in the brain. And IDO presents mainly in the cells of the immune system and in the body elsewhere where there is oxidative stress. And TDO is specific only to tryptophan, and IDO is not specific only to tryptophan, but specific to the metabolites and chemicals which have indole rings. So in case of ideal activity, then the metabolism shifted away from the liver to immune system, and this ideal presents in the microglia, astrocytes, and neurons in the brain. So the metabolism shifted away from the liver, and this ideal degrades also serotonin and melatonin. And then this metabolism continued to the downstream pathway where the quinolinic acid, which is NMDA receptor agonist, so that can induce excitotoxicity, and that can be counteracted by kynurenic acid, which is an NMDA receptor antagonist. So the interaction between these downstream metabolites has impact on the other neurotransmitter mechanism. So how this can happen? So here we have this metabolism which is enhanced by pro-inflammatory type of cytokines or molecules and suppressed by anti-inflammatory molecules. So when we have inflammation or infection, stress, then these pro-inflammatory molecules activate these ideal enzyme and another enzyme called kynurenine 3 monooxygenase enzyme. So that shifted this metabolism to this arm, and the metabolism has two arms. Yeah, so it shifted to this arm. And this arm is important because from this arm we can get energy and NAD, which we need during inflammation or stress, so the cells need energy. However, this increase of kynurenine can also increase the other kynurenic acid. And in this case, when we have increased tryptophan breakdown, we have less serotonin and more of these metabolites like 3-hydroxykynurenine and quinolinic acid because of the activation of this specific enzyme. And normally this kynurenic acid is reduced, but when the kynurenine is very much increased, then kynurenic acid can also be increased. So like in the previous talk, you can see the rebound phenomenon here as well. So cortisol can further enhance this metabolism, and in the brain, this production of kynurenic acid occurs in the astrocytes, and the other arm is mainly these metabolites are produced by activated microglia. And as I explained, this quinolinic acid and kynurenic acid can counteract at the NMDA receptor, so this quinolinic induce excitotoxicity and kynurenic counteract this excitotoxicity. So when they are in a balance, then we don't have problem, but when we have accumulation of toxic metabolites, then we have excitotoxicity in the brain. So even though this kynurenic acid can counteract this excitotoxicity through an NMDA receptor, that is also the antagonist of alpha-7 nicotinic acetylcholine receptor. And therefore, when this kynurenic acid is abnormally increased with this, either with this rebound phenomenon or either no IDO is activated, however, only DDO is activated, therefore we have only high kynurenine and increase in the whole metabolism. In this case, kynurenic acid can block this alpha-7 receptor action, and then it can disturb the dopaminergic neurotransmission. This can also block non-alpha-7 nicotinic acetylcholine receptor, and through this it can disturb the noradrenergic neurotransmission as well. And as you all know, these astrocytes are very important in glutamatergic neurotransmission, and from this metabolism, this 3-hydroxykynurenine and quinolinic acid, they can induce apoptosis of astrocytes. So when we have apoptosis of astrocytes because of abnormally increase in these metabolites, then the glutamatergic neurotransmission is disturbed as well. So when we have low serotonin availability and astrocytes apoptosis, we have low synthesis of neurotrophic factors as well. So in this way, when we have this immune activation, and also this oxidative stress is involved here to activate these enzymes. So immune activation, high oxidative stress, high pro-inflammatory molecule. And when this situation goes chronic, and then we have abnormality and imbalance in our neuronal glial network, and that can induce imbalances in the neurochemistry, and that can result in psychiatric disorders or chronicity of the diseases, or maybe drug resistance. So now I will go through some results that indicate how these metabolites are influenced by the psychopharmacology and how these metabolites can say about psychopharmacology. So in depression, we can see that this neuroprotective kynurenic acid, so this is NMDA receptor antagonist. So this has a high discrimination between patients and control when there is a cutoff of 27.6 nanomole per liter in the serum. And when we give antidepressant treatment for 6 weeks, in overall group, we see no significant change, but when we analyze only for drug-naive first episode patients, we can see this ratio of this protective molecule. So how much of kynurenine will go to this protective arm that is significantly increased after 6 weeks antidepressant treatment. And in our another study in collaboration with Chicago, there in escitalopram monotherapy and quetiapine monotherapy, we have 2 different studies, and we can see that about 12 weeks, then this neurotoxic, this astrocytes apoptotic 3-hydroxykynurenine level is significantly decreased. So it needs a little bit of long-term treatment, about 12 weeks. And this finding was supported by the finding of this Polish group. They show in vitro study that these antidepressants, different antidepressants, can increase this protective kynurenic acid and reduce this toxic 3-hydroxykynurenine in astrocytes cultures. So how we can use these metabolites to predict the treatment response. So in our study, one study, we have overall responders and non-responders. And we can see the responders, they have high kynurenine to tryptophan ratio. So in this study, we also give, we have 2 groups, and one group is treated with anti-inflammatory COX-2 inhibitor. So when you have inflammatory element in your pathophysiology, in the body, those patients, they respond to COX-2 inhibitor very well. And the non-responders, so here responders, non-responders, when we make the ratio between this toxic metabolite, quinolinic acid, to kynurenine, so how much of kynurenine goes to this toxic metabolites? So when you have more toxic metabolites in the, it can be detected in your serum, then you have less chance to respond the therapy. And in the cerebrospinal fluid also, when you have high protective metabolites against toxic metabolites, then the response to treatment is better. So what is in the brain? So in the brain, also when we detect this neurotoxic quinolinic acid positive microglia, then we can see here, so major depression, bipolar depression, These post-mortem brain samples, these are from the suicidal patients, and these are normal death. So here you can see that in depressed suicide, the quinolinic acid positive microglial cells, the density is the highest, and the bipolar is in the middle, and when it compared to normal death. So you can see that in suicidal brain, this quinolinic acid is increased. And also we can see in our patient serum studies, when the serum quinolinic acid is high, the psychomotor agitation, the symptom is high. So from another group from Sweden, they also show that in the CSF, in suicidal attempters, regardless of the psychiatric disorder, so either depression or schizophrenia, the quinolinic acid level is increased. So compared to protective, quin is much higher, so quinolinic acid is high, and it has association with interleukin-6, which is pro-inflammatory molecule, and also suicidal score.
2 minutes.
Yep. So when we move to schizophrenia, then in schizophrenia it's a little different. This toxic 3-hydroxykynurenine is significantly high, and after 6-week antipsychotic treatment, it is reduced. So it is more prominent than reduction in protective metabolite. And this is in chronic schizophrenia. So in schizophrenia, we have to be careful that it is different between acute and chronic state. So here also, you can see when we have on admission this high protective metabolite, then the change of the symptoms are better. And when we have high toxic metabolite, the change of the symptoms are lower. And in the cerebrospinal fluid also, you can see similar to affective disorder, the higher the protective metabolite in the CSF, the better the clinical outcome. And the studies in the brain are still in progress, so hopefully next time, if I meet you all again, I can give more information. So to summarize, we can see mild immune activation in the psychiatric disorders, especially depression and schizophrenia, and that enhanced the tryptophan breakdown and shifted the metabolism to the toxic part. And the cerebrospinal fluid and brain kynurenines also indicated the imbalance of the metabolism. And currently available antidepressants and mood disorders, they can correct the biochemical imbalances, but you have to treat them at least about 12 weeks. However, currently available antipsychotics are quite efficient in reducing or rebalancing this metabolism. And so manipulation of kynurenine pathway could be future perspectives. So for example, like ketamine, which has NMDA receptor antagonist action, can cure these depressive symptoms, severe depression symptoms. And so how can we use that? For example, if we can detect the increase in quinolinic acid in depressed patients, then we can predict that they have a risk of suicide, and then maybe we can give this ketamine therapy to prevent suicide. So this is one of the examples how we can use these metabolites as biomarker. So these, we hope that in the near future we can use these biomarkers for early diagnosis or prediction and prognosis or treatment of choice in personalized medicine. So last but not least, I would like to point out that this metabolism is the example that we cannot grab just one molecule and think that this one molecule will change the body or the brain of the patients. because even in this one metabolism, we need more molecules to change. And this metabolism is only a little piece of the whole puzzle in our body. So like these 6 triangles, only when these 6 all combine together, then we have a complete hexagon. And it would be harmony if one change, other also change accordingly. So interaction between the other systems. So if we study only one piece at one time, and if we don't collaborate, then finally we think we have a hexagon, but that will be far away from our real body system. So if we really want to bring something for our patients, I think we need collaboration. We need to collaborate with our colleagues from medicine and other disciplines, and hopefully in this way we can bring something for our patients in the near future. And I would also like to thank all my collaborators and the study subjects and animals also. I didn't show the data from animal study today, but without them I can't present anything today, so I thank them all and also for your attention. Thank you.